In this lecture, we will talk about nutrition therapy for patients who undergo kidney transplants. A lot of this information covered in this lecture also applies to patients who undergo other organ transplants, including liver transplants. Currently in the United States, there's a huge imbalance between the number of kidney donors and the number of patients who need kidney transplants. There's also a health disparity issue associated with the kidney transplants, as well as other organ transplants too. Minority patients are having a much more challenging time finding matching donors. As depicted in this figure, kidney transplant is not done by surgically removal of one of the kidneys to be placed in so we don't surgically remove one of the host kidneys in order to place in the donor's kidney back in that spot. No, we'll leave both kidneys in the host as they are. Instead, we connect the donor's kidneys to the host's bladder and then direct the urine formed in the donor's kidneys into the urinary bladder, and then eventually it gets disposed out of the host's body. The next few slides covers information on transplant immunology. So it is from the chapter on the immune system. We've put it here because the contents are more relevant to the condition being discussed here, which is organ transplant. And there are different types of organ transplants. One is called autograft, meaning that the graft is coming from the patient, so him or herself. So basically, we're just cutting off one part of the patient's body and putting it somewhere else on the same person's body. For example, if unfortunately someone's in an accident and loses their index finger, we know that this is like the most important finger for human beings. So in that case, the surgeon may cut off the patient's, maybe like their second toe, and move it to where the index finger was so that we can maximize the function of the patient's hand. Or if we recall what we saw with burn units where we used unharmed skin from another part of the patient's body that was taken and used to cover the part of the body that was affected by the burn. Isograft refers to transplants done between identical twins. So the donor and the recipient are identical twins. Obviously, that means that their genetic backgrounds are identical, so it's less likely for them to get rejection. However, a majority of transplants are done as allograft. So we have allo, which means different. So that means that the donor and the recipient are non-twin members of the same species. This means they could be siblings, but not identical twins, or they could be a parent, child, uncle, nephew, or even just total strangers. Obviously, in allografts, the people involved will have a more diverse genetic background, therefore a rejection rate is higher. And in some cases, we can do xenografting, meaning the graft is from a different species. And this can be more challenging, but usually the tissue that are used in this scenario are not vascularized, meaning that under normal conditions, this tissue does not have blood vessels, or not a lot of blood vessels, and this can help reduce the rejection risk because we know white blood cells are the immune cells, and white blood cells flow inside blood vessels within the bloodstream. Therefore, when a tissue doesn't have any blood vessels, the white blood cells cannot really reach it. When we talk about transplant rejection, that means that the donated organ and the host and the body of the host are not compatible, so they're attacking each other. It could be host versus graft rejection or graft versus host rejection. But in either case, the outcome is the same and the transplant is not working well. And we might have to do another one if we're able to find another matching donor, or the transplant will eventually fail. So the first set, rejection, occurs shortly after the surgery, so about 11 to 17 days afterwards. Then there are also delayed rejections that can happen months to years after the surgery. So this is why it's important after a patient comes out of the acute period immediately after transplant that they still need to be taking an immunosuppressant. The reason is that we want to prevent that second set rejection, which comes a lot later. To ensure or to maximize the success chance for organ transplants, the donor and potential recipient need to go through the matching process. So if someone at stage 5 CKD would like to go through with having a kidney transplant, this person will have to give blood and the necessary information so that we can have this person's blood type and human leukocyte antigen on file. So that's the HLA. Then if the database, so they check the database, and if a donor shows up with a similar profile, HLA, then we would call that a match. So HLA has multiple sites that we checked, and the more sites that are matched between the donor and the recipient, the more likely the transplant is to succeed for the long term. So if all the sites are matched, then we would say, okay, this person's found a perfect match. A lot of immunosuppressants have severe nutritional side effects, so that's why a lot of patients who have successfully undergone transplant surgery will have a lot of nutrition-related conditions afterwards during the maintenance stage. This table here summarizes a few commonly used immunosuppressants and their nutrition side effects. So please go through them. There's no need to memorize the specific names, but you should at least have this idea in your mind. If someone has a med history of taking these medications, we would then need to look up the interaction between these meds and nutrients. For post-transplant patients, we usually divide the period after the surgery into two phases. One is acute, the other is chronic. And the nutrition recommendations for these two phases are different. For example, protein and energy needs are elevated for the acute phase patients. And if we think about this, this should make sense, not difficult to understand, because the patient just came out of a major surgery. Therefore, to recover, just like any post-surgery patient, they will need a higher amount of energy and protein for the surgical wounds to heal. So this is a metabolic stress condition, right? So in the first few weeks after surgery, the patient's body should recover from what was done in surgery, and then after we enter the maintenance stage or the chronic phase. So that's when usually the RDA for protein applies. That should be adequate. No need to provide an extra amount of protein. We want to have a low saturated fat diet for these patients because, as we'll mention, a lot of these patients after this type of surgery have increased risk for cardiovascular disease. This table summarizes the current nutrition guidelines for adult patients who undergo kidney transplants. As we can see, the recommendations are divided into those for the acute phase and the recommendations for chronic phase. So as we just talked about, using protein as an example, we can see that it calls for quite a higher amount of protein in the acute phase. And then in the chronic phase, 0.8 to 1, that's pretty much the RDA level for adults. And same thing if we look at energy. So 30 to 35 calories per kilo during the acute phase, and then to maintain desirable weight in the chronic phase. If we have post-op complications, then we will have to provide even more. But once the patient moves into the chronic phase, our goal is just to provide enough to maintain a desirable weight. So same thing for these other nutrients along the table. So specifically in relation to carbohydrates, patients post-transplant usually have glucose intolerance, so this is something we need to consider. Therefore, we want to emphasize fiber intake. And we mentioned overall, we want the post-transplant patients to be on a low-fat diet, especially one that's low in saturated fat. Hypertension is common among these patients, so sodium restriction is often indicated. During the acute phase, potassium restriction is also necessary. Again, to maintain the harmony between the host body and the donor's organ, the patient needs to be continually taking that immunosuppressant. And this will lead to long-term nutrition side effects, so we really want to be closely monitoring everything. And to note, people who are on immunosuppressant should avoid grapefruit and grapefruit juice. The reason is that in grapefruit and its juice, there are some enzymes that can really interact with a lot of medications. They change the potency and the balance within the patient's body. So in addition to the immunosuppressant, for example, grapefruit juice can also interact with Lipitor, which is, the bestseller of cholesterol-lowering medications. So when patients receive this prescription, the pharmacy or the pharm tech will tell the patient, when you're on this medication, please don't eat grapefruits or drink grapefruit juice. So another summary of immunosuppressants and potential adverse effects. So a lot have nutritional implications. So as we can see here, nausea and vomiting is quite common as a side effect. Some can also cause diarrhea, abdominal pain, so those GI issues. They could also affect our appetite, so then our intake, and also how our digestion and absorption play out. So specifically, drug-nutrient interactions for medications relevant to the renal system are in this table. So this table does not just have immunosuppressants. For example, we have alcohol, diuretics, anticoagulation medications as well. So it's a good summary for different types of medication, talking about the different conditions, and then the nutritional implications related to the renal system that may come about as well. Post-transplant patients are at a very high risk for CVD, and also liver disorder is very common. Some people will be put on a lipid-lowering medication, and a lot of patients after the surgery also will have a low magnesium level. And we know that magnesium is something that we can deliver easily through the IV route if necessary. Weight gain is also common. So a lot of these are part of the side effects from the medication we mentioned before. So of course, when they have dyslipidemia with weight gain, all of these, and we mentioned the glucose intolerance, it's almost like a metabolic imbalance as we see in metabolic syndrome. So, it's no wonder that they have an increased risk of cardiovascular disease. For these patients, what we emphasize is a modification in the diet for sure. We have specific recommendations that they should follow, but also there will be a lot of behavioral modification counseling education going on because, again, the kidney that is working now is from someone else. So this is a factor that's never going to change from here on out. We will have to have this lifetime commitment to monitor and to keep the modification to the lifestyle. Otherwise, there will be negative outcomes. And exercising as tolerated is definitely helpful for these patients, as of course we see in many other patients also. Osteoporosis and altered vitamin D status are also not uncommon for these patients. So when patients are having a rejection reaction or we're trying to prevent rejection, oftentimes corticosteroids are prescribed, and this category of hormones can change our glucose tolerance and also mobilize the bone calcium reserve. So we may have high calcium in the urine. And if that's the case, we'll basically have to, based on the specific lab markers and dynamics, we will have to supply supplements as necessary. Then we also mentioned before that serum potassium can also be affected by calcium status, so we need to monitor that as well. Again, we mentioned the impacts of corticosteroids. Hormones are all very potent, first messengers by definition. And the reason why these patients are given this hormone is that hormones are very potent anti-inflammatory response agents, and the rejection reaction really involves inflammation. So by calming down the inflammation response by using corticosteroids, we can hopefully manage the rejection. But again, as we mentioned, this could also affect the metabolism of glucose. And glucose intolerance is a common side effect of these hormones, and also it can also affect the distribution of fat tissue in the body. So usually people who are on this hormone for a long time, their body fat congregates around their torso rather than in their limbs. So they may have kind of a stocky looking torso but very thin, slim limbs. When rejection does occur, obviously we're talking about an elevated disease state, mainly to the failure of the donor's organ, and of course inflammation would be involved here. So during the rejection reaction, protein and calorie requirements will be higher than they are during that chronic stage. So for monitoring and evaluation, we have the clinical outcomes we can look at. We have to check to see if the transplanted organ is still functioning and if there's any rejection going on. And then on top of that, those well-known long-term complications need to be monitored and make sure that we're controlling for everything. For example, the risk for cardiovascular disease, weight gain, things like that. As far as the RD is concerned, in addition to the clinical outcomes, we also need to check the compliance for dietary advice. So remember, this is a lifetime commitment, and we very often have to reinforce the education and the counseling that we've previously done with these patients so that they continue to be compliant.